My name is Joseph Pincus, and I'll be presenting our work on fecal urgency incontinence versus passive fecal leakage, 3D and dynamic pelvic floor ultrasound findings. We have no disclosures. Fecal incontinence can be split into two subtypes, fecal urgency incontinence and passive fecal leakage. Though it is straightforward to recognize these two subtypes clinically, the underlying pathophysiology is still under investigation. Traditionally, it was thought that fecal urgency incontinence is associated with external anal sphincter defects. Conversely, passive fecal leakage was thought to be associated with internal anal sphincter defects. We sought to use pelvic floor ultrasonography with both 3D and dynamic elements to further investigate the anatomic parameters in these two clinical subtypes of fecal incontinence. This was a retrospective cross-sectional study. Patients were eligible that answered yes to questions 9, 10, or 13 of the PFDI 20. At the index visit, patients underwent a detailed history and physical exam. Endovaginal and endoanal ultrasounds were performed with 3D imaging and dynamic imaging of the posterior compartment. Patients were categorized as having fecal urgency incontinence, dominant fecal incontinence, if urgency incontinence events occurred twice as frequently as passive fecal leakage events. Patients were categorized as having passive fecal leakage, dominant fecal incontinence, if those events occurred twice as frequently as fecal urgency incontinence events. If neither pattern was dominant, patients were categorized as having both types of fecal incontinent patterns. Ultrasound techniques were performed as previously published in measuring the structures of the pelvic floor. However, I'd like to highlight the 2D dynamic ultrasound. Here, we demonstrate the posterior compartment with the cul-de-sac to the left and the levator plate to the right. Image A on the left is a patient at rest. Image B on the right is a patient on full Valsalva. This patient shortens the distance between the cul-de-sac and the levator plate on Valsalva. This phenomenon is called rectal folding or rectal sliding and is associated with decreased attachments of the rectum and increased rectal mobility. We enrolled 145 patients, 57 in the urge predominant group and 69 in the passive predominant group, with the remaining 19 with both symptom patterns. Patients with urge dominant fecal incontinence were noted to be younger than patients with passive fecal leakage dominant fecal incontinence. Otherwise, their demographic characteristics were similar. In terms of stool pattern and physical exam findings, our subtypes were similar, except in regard to bowel movement frequency, where patients with urge dominant fecal incontinence had more frequent bowel movements. Patients with urge dominant fecal incontinence also had looser stools than patients with passive fecal leakage dominant fecal incontinence. Our ultrasound findings reveal statistically significant differences related to the mobility of the rectum. However, the remainder of our ultrasound parameters, including minimal levator hiatus, rectal area, and an examination of sphincteric defects, demonstrated no differences between the subtypes. On multivariate regression analysis, none of the variables that we looked at remained statistically significant. Our study had several strengths and weaknesses. It's the first study that uses dynamic ultrasound to characterize fecal incontinence subtypes, and it had a relatively large cohort of patients. Some of the weaknesses include the retrospective nature, that the measurements were taken at a single time point, and the absence of quantitative anorectal manometry information. In conclusion, our study demonstrates that patients with urge dominant fecal incontinence had more frequent bowel movements and a higher prevalence of loose stool compared with patients with passive fecal leakage dominant fecal incontinence. Additionally, we demonstrated that patients with increased rectal mobility were more likely to have urge dominant fecal incontinence. These are our references, and we're happy to take any questions. Thank you.